And share my screen. Just give me one moment. Okay, can you guys see the slides okay?
Yes, we can see them.
Okay, great, perfect, thanks. All right, so this is going to be a super condensed, fast version of pediatric emergency medicine. And primarily, I'm going to focus on how kids are different from adults, since you all know adults super well. All right, so let's talk about arrest situations first. I think you guys know this. Primary cardiac arrhythmias are incredibly rare in pediatric populations. They don't arrest because of a cardiac issue. They usually arrest because of a respiratory issue. They can also arrest because of shock, either from dehydration or sometimes sepsis. When we talk about the pediatric airway, remember that it's anatomically different. It's smaller, it's shorter, the larynx is higher, and the airway is more anterior than you would expect compared to adults. The peds airway is considered to be more of a funnel shape as opposed to a cylinder, and the narrowest part of the peds airway is the cricoid. In terms of what tube size we use, we pretty much in every peds patient, we use cuffed tubes now, except for like in the neonates. And you can estimate cuffed tube size based on age. So age divided by 4 at 3.5. We're pretty much using glide scopes and VL with almost all of our patients. But if you have to do DL in a peds patient, use a Miller blade. And remember, the whole point of the Miller blade is to get the epiglottis out of the way. If you're going to use a glide scope, get a shorter, smaller blade and really try and get into that vallecula to get the epiglottis out of the way. The peds epiglottis is usually a lot more floppy than the adult epiglottis. In terms of defibrillation and cardioversion, sometimes you'll have peds paddles. If not, you can use adult paddles in kids greater than 8 years of age or greater than 55 kilos. Again, in peds, everything is weight-based. So if you have to defibrillate a kid, which is pretty rare, initial defibrillation dose is going to be 2 joules per kilo, and then subsequent doses are going to be 4 joules per kilo. If you have to cardiovert a kid, which I don't think I've ever had to do in 20 years of doing this, your initial dose is going to be 0.5 to 1 joule per kilo, and then 1 to 2 joules per kilo. In terms of access for a peds patient, after 3 attempts or 90 seconds, place an IO. We usually place an IO. It's going to be an anterior tibial IO. If you have a neonate, the preferred way to get meds into a neonate is through an umbilical vein catheter, and that might be something on the boards. The initial dose of epi for a peds patient is 0.01 mg per kilo, which works out to be 0.1 cc's per kilo, the 1 to 10,000. Atropine dose is 0.02 mg per kilo with a 0.1 milligram minimum. Otherwise, you can get a bradycardia. 0.5 milligrams is the max dose in a peds patient. If you need to give glucose in a peds patient, you can give 2 to 4 cc's per kilo of D25. I usually do 2 cc's per kilo. I think you guys probably know this, but whatever dextrose solution you're using, whatever the number is after 25, your cc's per kilo should equal 50. So D25, if you want to give a bolus for hypoglycemia, give 2 cc's per kilo. If you have D10, and that's the only thing available, give 5 cc's per kilo. The adenosine dose, if you need it for SVT, is 0.1 to 0.3 mg per kilo. So you can start with 0.1, and then with subsequent doses, do 0.3 mg per kilo. Let's move on to some neonate stuff. So say that you have an infant coming in, being born in the ED, and they are postdates, and they are born in respiratory distress, and you get a portable chest film, and you see all this haziness. So I'm gonna actually, instead of asking you guys the question, asking you to participate, just because of time, I'm just gonna sort of tell you the answer. So this scenario and this x-ray should make you think of meconium aspiration. More common in postdates infants, they'll usually give you a scenario in which you see thick meconium. We don't really do that much for meconium anymore. There used to be all this talk of like sort of suctioning at the perineum, maybe even sometimes intubating to pull out the meconium. We don't really do any of that anymore. Just be aware though, thick meconium in a depressed infant, that has a high risk for complications and mortality. Say you have another neonate born in the ED, and again, they're presenting with respiratory distress shortly after birth. You get an X-ray, and it looks like this. Here in the left chest, you can see loops of bowel. So this should make you think of a congenital diaphragmatic hernia. A left is more common than a right. They'll present with respiratory distress at birth. You'll see on chest X-ray air-filled bowel loops. They'll have hypoplastic lungs. These kids need to be intubated immediately. They need to receive IV fluids, an OG tube, and they need to go to surgery. Next sort of neonatal issue that you might encounter is a baby who's born that looks like this. This, I think, is probably, this is either an omphalocele or gastroschisis. An omphalocele is covered by the peritoneal sac. A gastroschisis is not covered by a peritoneal sac. Usually, omphalocele are associated with abnormalities, especially chromosomal abnormalities in about half of infants. And basically, if you have a baby who's born like this in ED, place saline-soaked gauze over the part of the bowel that's out, keeps them warm, place an OG tube to decompress the GI tract, IV fluids, antibiotics, and they need to go to ped surgery. Let's see. Next X-ray. Say this is an infant coming in about a week old, was born a little bit early and was a little bit underweight. And they're coming in because they're having difficulty tolerating their feeds. The parents are just noticing they're sort of spitting up a lot more. The belly seems a little bit distended, and you get this X-ray. So that scenario, and then this X-ray should make you think of neck, so necrotizing enterocolitis. This X-ray shows air in the bowel wall. So this is pneumatosis intestinalis. So usually we think of neck as a problem that happens in the neonatal ICU with low birth weight preterm infants, but can also occur in term infants, especially ones who are born just a little bit premature or born with a low birth weight. Usually they'll present with abdominal extension, not tolerating their feeds well. Eventually will progress to bilious emesis. They'll get glycopositive stools. They may develop abdominal wall tenderness and erythema. On X-ray, sort of later findings are pneumatosis intestinalis, portal vein gas, and you may see air fluid levels. These kids can get pretty sick, so they need to be pan-cultured just because of they can get gut flora translocating into the bloodstream, and they can become bacteremic and septic. They need to be kept NPO. They need to be starting antibiotics, and ped surgery needs to be involved with their care. All right, so this baby is born at term, and he is crying and he's vigorous, and this is what he looks like a few minutes after birth. Normal, not normal. The things to notice here are that his hands and his feet are cyanotic. So this is acrocyanosis. This is a normal finding in a normal term neonate. So this is not cyanosis that you need to worry about just because it's only peripheral. It usually is because of vasomotor instability that the neonates will have when they're first born, and then it'll usually resolve at some point during the first day of life. But this brings up the topic of cyanosis in infants. So if you have a young neonate coming in with cyanosis, your differential should include congenital heart disease, including the 5 Ts, which we'll talk about: primary lung disease, hypoventilation, methemoglobinemia, and sepsis. The way you can differentiate a primary pulmonary process from congenital heart disease, in which there's right to left shunt, versus some of the other causes, is to do what's called an hyperoxia test, where you basically expose the infant to 100% FiO2 through a non-rebreather for about 10 minutes. And then you check an ABG afterwards, and you look at the PaO2. And basically, if the PaO2, if you can't get it past 100, this is consistent with a right to left shunt, so a congenital heart disease causing cyanosis, or methemoglobinemia. But again, remember, peripheral cyanosis just peripherally is common in the first few days of life. In terms of the cyanotic heart lesions, we talk about 5 T's. So transposition of the great arteries, tetralogy of flow, total anomalous pulmonary venous return, truncus arteriosus, and tricuspid atresia. And again, with the hyperoxia test, these kids won't improve with their PaO2 much when you give them 100% FiO2. Transposition of the great arteries is the most common cause of newborns presenting with cyanosis. That's not just peripheral cyanosis. After that, if they present with cyanosis after about a year of age and they have some sort of congenital heart disease, think tetralogy of Fallot. Epstein's anomaly, just so you all know, is basically where the septal leaflet of the tricuspid valve gets displaced into the ventricle towards the apex, and this results in what people say is atrialization of the right ventricle. Say you have a kid coming in for whatever cardiac complaint or cyanosis, and they show you this X-ray. The thing to notice about this X-ray is this heart shape. So it looks very boot-shaped, and that should automatically make you think of tetralogy of Fallot. There are 4 components to tetralogy of Fallot. I always like to think of how one causes the other. So the first thing I think of with tetralogy of Fallot is a VSD. And because of the VSD, that can cause the aorta to become an overriding aorta, which then results in right ventricular outflow tract obstruction or pulmonary stenosis, which then over time can lead to RVH. These kids will present with cyanosis, clubbing because of the hypoxia, a loud single second heart sound because of increased pulmonary vascular pressures or pulmonary pressures. On X-ray, you'll see a boot-shaped heart again. You might see reduced vascular markings. On EKG, you may see signs of right axis deviation. They may also have signs of right ventricular hypertrophy. A thing that I've seen on boards, not too infrequently, is TET spells in a kid who has tetralogy of Fallot. And basically what a TET spell is when there's increased right to left shunting in a kid with tetralogy of Fallot. And basically what happens here is they become cyanotic, they look really unwell, and it happens because your pulmonary vascular resistance goes up. And so when it's much higher than your systemic vascular resistance, you get increased right to left shunting. This is more common in younger kids, and it's oftentimes precipitated by exertion, feeding, straining, crying, things that increase your pulmonary vascular resistance. When you think about how to sort of treat a TET spell, think of either reducing pulmonary vascular resistance, or increasing systemic vascular resistance, or reducing systemic venous return will also help with a TET spell. So one thing you can do is you can put the kid in a prone knee chest position. And what this does is it basically relaxes the patient. It increases their systemic vascular resistance, and it reduces systemic venous return. You can also give them morphine, which will reduce their respiratory rate and decrease systemic venous return. Oxygen will reduce your pulmonary vascular resistance. Propranolol will reduce cardiac contractility and also reduce right pulmonary outflow tract obstruction. And then phenylephrine, if you need to give it, will increase your systemic vascular resistance. And then all of those things will reduce the right to left shunting that's causing the TET spell. Let's move on to acyanotic heart lesions. So the most common congenital heart anomaly is an acyanotic lesion, which is a VSD. Initially, small defects can become asymptomatic, but during the first few weeks of life, infants with large defects can develop CHF. And the reason why they present during the first few weeks of life is because, remember, when a baby is first born, they've had a lot of fluid in their lungs. So their pulmonary vascular resistance is elevated compared to their systemic vascular resistance. But then during the first few weeks of life, what happens is that as that fluid sort of comes out of their system, their pulmonary vascular resistance drops to a more normal pulmonary vascular resistance for an extrauterine being. And as a result, they start to get more left to right shunting through a VSD, and they can present with CHF. So they may present with tachypnea, grunting, fatigue with feeding. Remember, feeding is an infant's form of exercise. That's when you'll start to see signs or symptoms of CHF exacerbation. Aortic stenosis is also another acyanotic heart lesion that you can see in patients. It usually presents in older kids with sort of symptoms I think you would expect. So reduced exercise tolerance, chest pain, syncope with exercise. In kids, it's usually due to a bicuspid valve. In terms of other acyanotic heart lesions, again, remember, like with boards and all these sort of standardized exams, it's a lot of sort of key words. So patent ductus arteriosus, you might get a scenario in which there are bounding pulses, a continuous machinery murmur, a thrill at the suprasternal notch, coarctation, I think you guys know this, hypertension in the upper extremities with reduced pulses in the lower extremities. Let's briefly talk about ductal dependent lesions. So ductal dependent lesions are basically lesions, cardiac lesions in which the right and left side of the heart flow between these two sides is dependent entirely on a patent ductus arteriosus. And the ductus arteriosus in normal infants usually closes within the first few hours or days. And so as that ductus closes, if a patient has a ductal dependent lesion, they'll start to look sicker and sicker. They'll present in severe shock. And the way you sort of temporize things until you can get to the definitive care is by giving prostaglandin E1, which basically dilates the ductus. The dose is there, 0.05 to 0.1 mics per kilo per minute. It's a drip. Side effects of the prostaglandin E1 are hypotension, apnea, and seizure. And so your ductal dependent lesions include like hypoplastic left heart, complete right-sided outflow obstruction, tricuspid atresia, critical AS, et cetera. All right, so in terms of reasons to have CHF in a child, and I think I saw this table from a board review book. I'm not sure if you need to memorize it, but after about 1 to 2 years of age, you start thinking of sort of more acquired things like myocarditis, cardiomyopathy, severe anemia, Kawasaki, which we'll talk about. I'm gonna skip through this because I think you already know these signs and symptoms of congestive heart failure. All right, airway emergencies. I think you guys know this also. When kids have respiratory distress, they'll have nasal flaring, they'll have retractions, they'll have grunting, which basically they're trying to auto peep. And those are the signs of respiratory distress. Let's see. All right. Moving on to other airway issues. If you're worried that a child has a foreign body and has aspirated a foreign body that's causing obstruction in one main stem bronchus, the x-rays that you want to get are lateral decubitus x-rays. And the reason why is because if you have a foreign body that's basically causing obstruction of the main stem bronchus, it can result in this ball valve effect, which is basically when air can get in but can't come out. And as a result, the side that has the obstruction will become hyperinflated. And the way you can pick this up is by getting the lateral decubitus filled on the patient. So say something is stuck in the right main stem bronchus. If you have a patient who has a foreign body there causing obstruction, basically when you get that decubitus film, that right lung will look to be the same size as the left lung or even bigger. It might be hyperinflated. If you have someone who doesn't have an obstruction there and you lay them down on the right side for a lateral decube film, what happens is because of gravity, that right lung should be smaller or more compressed compared to the left. And the same thing holds true if you have something stuck in the left main stem bronchus. Let's see, I think we've talked about this. You should suspect a missed foreign body in patients who have recurrent pneumonia in the same location over and over again. Then you should suspect that maybe they had a foreign body there, and this is why they're getting pneumonias repeatedly in the same place. Kid comes in, okay, this I don't think is in my slides, but I just want to review this. You can see button battery ingestions on x-ray. You can actually see like the double rim of an x-ray. So if you get an x-ray like that and say there's a foreign body, look closely at the circular object to make sure it's not a button battery. If it's a button battery, that's an airway emergency and that button battery needs to come out. because of the risk of perforation. More commonly probably is a kid will swallow a coin. You can differentiate where that coin is either in the esophagus or the airway based on what you see on PA films and lateral films. So if the coin, if a circular coin is in the esophagus, when you look on a PA film, you'll see the coin en face. And then when you look at the lateral film, it'll be on edge. And opposite is what happens if it goes into the airway. And I almost think of, I like to always remember it by thinking of a coin having to go through the slot created by the vocal cords to go into the airway. So basically, if you get a PA film and that coin is on edge on the PA film, it's in the airway. And then on lateral, it should be on face, on face. In terms, sometimes if you see, sometimes you may not see a foreign body. I think I had a kid who I think swallowed a ton of grated carrots and got into the airway. And basically the way you pick up that foreign body is by MRI if you can get it. And they may need laryngoscopy, bronchoscopy for retrieval. Okay, all right, let's look at this x-ray. This is from a kid who comes in with stridor. They don't look well. They're sitting upright, sort of in a sniffing position. They're drooling. What you're supposed to notice here is the thumbprint epiglottis. I think this is actually, yeah, right there, the thumbprint epiglottis. So that brings us to epiglottitis, which is considered an airway emergency. We don't really see it much at all because mostly everybody's immunized, but you suspect it in an unimmunized patient, maybe someone who's a migrant who hasn't had all their immunizations. It can be caused by Haemophilus, group A strep, strep pneumo, Staph aureus. They are toxic appearing. With these kids, you have to be very careful with them not to minimize agitation. And basically to get anesthesia, ENT, involved as soon as possible. They should be, if you need to intubate them, it should be double setup. So that way, if the intubation goes south, you can quickly do a crike. Basically, treatment after you stabilize the airway is antibiotics and obviously admission to the ICU. This is another kid, young kid coming in with stridor, but this kid does not look that sick. Their story is they've had URI symptoms for a few days and then woke up in the middle of the night with this like stridor. And basically the parents took them out of the apartment to bring them into the PZD, and now they look a lot better. And then you hear them from triage with their barking seal-like cough. So this is a very typical story for croup. Usually occurs in the younger kids. What we do to treat them is, and here my slide says usually parainfluenza, they can be from any respiratory virus. Usually all these kids will get a dose of PO decadron. And basically the whole idea of that is to reduce the inflammation until the worst part of the croup is over. If they have respiratory distress or inspiratory stridor at rest, then usually those kids will, then we treat those kids with racemic epi. If they have inspiratory stridor only when they get agitated and when they get upset, usually we don't need racemic epi and we can just give the PO decadron and send them home as long as they sort of go back to, you know, normal respiratory effort. On x-ray, you'll see the steeple sign. You can talk to the parents about keeping them hydrated, exposing them to cool mist or taking them into the shower if they wake up in the middle of the night uncomfortable. In terms of what to do if their symptoms are severe. So if you have a kid who basically gets racemic epi and their stridor at rest improves, but then it comes back a short time later, then usually that kid will need more racemic epi, and you may have to think about admitting them. So if we give racemic epi, there can be a rebound effect after you get racemic epi. So we usually watch these kids who get racemic epi for about 4 hours before we discharge them to home. If they just need repeated doses of racemic epi, or they're not really turning around with racemic epi, then consider Heliox for severe croup. Another airway emergency that can present as stridor is bacterial tracheitis. And these kids will be toxic. And they're usually stories they've had sort of a viral illness, maybe croup for a few days, and all of a sudden they look much worse. You should think of Staph aureus. They'll have high fevers. They'll be toxic appearing. They need to be admitted and given IV fluids, antibiotics, and they can get into trouble with their airways as well. All right. This is a kid who comes in, this looks like an x-ray from an older kid, but say it's a kid who comes in basically 18 months old, not really sort of, just sort of fatigued and tired. And the big thing is that they just won't take POs because it hurts. And they're febrile and they've been febrile for a few days. You get a lateral film because you're suspicious of a retropharyngeal abscess. And so you can see here, there's prevertebral soft tissue swelling. So retropharyngeal abscess, this usually happens in younger kids. I think I've seen it up to like kids 5, 6 years of age. And these kids will look really unwell. They're in a lot of pain. They're sort of refusing to eat, refusing to drink. And sometimes that's the only symptom, especially in like sort of a pre-verbal kid. And the way you sort of screen for initially is to get a lateral soft tissue neck x-ray. And you'll see the widened retropharyngeal space. In kids who have a retropharyngeal abscess, you should also get a chest x-ray because the retropharyngeal space is continuous with the mediastinum. And so you want to rule out mediastinitis. These kids need to be admitted to the ICU. They get antibiotics. And oftentimes ENT is consulted and involved in their care. All right. This is sort of very typical. You guys know this. 18-month-old kid comes in with cold symptoms and they've got crackles and wheezes on exam and they're sort of retracting. This is, bronchiolitis. We used to think of bronchiolitis as only an RSV thing, but as I think you all have seen, it can be caused by lots of different viruses. It usually happens in the younger kids. There are certain populations that are sort of risk for more severe bronchiolitis. That includes preemies, people with congenital heart disease, kids who are younger, so under 3 months of age. They're usually sicker during the first few days of their illness. In terms of how we treat it, a lot of times kids with bronchiolitis who aren't having a lot of respiratory distress can just be sent home with supportive care. The board's answer for how you treat bronchiolitis is basically supportive care, IV fluids, oxygen if needed, high flow nasal cannula O2 if you need it, positive pressure like BiPAP or CPAP if you need it, if you need more than that. The board's answer is that bronchiolitis does not respond to bronchodilators or racemic epi or steroids. Though in practice, probably in the past year, I think we've all, like the peds people have seen a lot more bronchodilator responsive bronchiolitis. And so I wonder if at some point guidelines will change, but board's answer is bronchiolitis should not be treated with bronchodilators. Let's move on to fever. So fever guidelines have changed over the past couple of years, and I think you guys know this already. Basically, the kids the neonates that absolutely need like the full workup with blood, urine, LP, empiric antibiotics is younger than 21 days of age with a fever. They're at increased risk for an SBI, a serious bacterial illness, because their immune system isn't that well developed, and also because they don't typically show the signs and symptoms of sepsis. So this is, for example, is our guideline for the 8 to 21 day age group that we use in our PZR at Cornell. Again, they get the full workup. It starts to get a little bit, I think, personally confusing after 21 days of age, so 22 to 28 days of age. You send off inflammatory markers. They may or may not need the LP. If the inflammatory markers are normal, they may not need the LP, but if you do the LP and it's normal, then maybe they don't need to stay. There's a little bit more, I think, vagueness with guidelines after 22 days of age. 29 to 60 days of age, usually you'll get urine, blood, and inflammatory markers. And then if everything is normal, then no LP and observation at home if it's a good social situation. In terms of organisms for sepsis, I guess in the neonates, remember it's Haemophilus, strep pneumo, and listeria. Older infants, strep pneumo, Neisseria meningitidis, Haemophilus. The sickle cell patients, think of the encapsulated organisms. All right, I'm going to skip through meningitis. Oh, I'm sorry, actually neonate bugs are GBS, E. coli, Listeria. I misspoke. Neonatal bugs, again, sorry, I misspoke. Both for sepsis and meningitis, think GBS, E. coli, and Listeria. Those are the neonatal bugs. All right, in terms of meningitis treatment for the neonates, you want to do AMP and Gent or cefotax. You don't want to give ceftriaxone in babies less than a month of age because there's an association with biliary sludging and hyperbilirubinemia. After 1 month of age, for empiric treatment for meningitis, you can give ceftriaxone. I just want to talk briefly about the role of steroids. There's not really a clear benefit. There was, this one study that looked at dexamethasone in kids with Haemophilus influenza and who are at risk for sensorineural hearing loss. And so maybe dexamethasone is considered then. We don't routinely give steroids in children or infants that we're concerned may have meningitis. In a child who you're concerned has meningitis, always think of acyclovir, especially like in a neonate, for example, with risk factors. So maternal HSV. Certain people should get prophylactic rifampin in patients who have for patients or contacts of patients with meningitis. So EMS or clinicians perform intubation, suctioning, mouth to mouth. They should get rifampin. Daycare, nursery contacts should get rifampin. Household contacts under 4 years of age, if it's HIB meningitis, should also get rifampin. All right, pneumonia. After the neonatal period, the most common cause for pneumonia is viral. I'm going to just go through a few sort of clinical pictures. I think there are sound effects. I apologize for the slide. I meant to take it out, but I haven't. All right, so I'm going to give you a couple of scenarios, and we're just going to go through what the most likely cause is based on the scenario. So URI symptoms for a few days, gradual onset lower tract symptoms, low-grade fever. They look fine on exam. Think viral. All right, next one is afebrile infant coughing for a couple of weeks. The cough is paroxysmal with an inspiratory whoop. They have some post-tussive emesis. Think pertussis. Sorry for the sound effects. All right, next is like a 10-year-old kid who comes in with a non-productive hacking cough. They have some inspiratory rales. They have some pharyngitis. You look at their ears, you see bullous laryngitis, otitis media. Think mycoplasma. 10-week-old with sort of what's called a staccato cough. They're tachypnic, but they're afebrile. Think chlamydia. Older child, like 15, acute onset high fever, cough, tachypnea. They look like they don't feel great, maybe a little toxic appearing. Think strep pneumo. All right, let's move on. Sorry, my slides just stopped. Okay, all right. All right, let's move on to pertussis. I think we've talked about this already. There are 3 stages to pertussis. There is the catarrhal stage, which I think is like a couple of weeks, followed by the paroxysmal stage where you have the whooping, the inspiratory whoop, followed by the convalescent stage. Younger infants with pertussis are at increased risk for, I think, apnea. We used to hospitalize younger infants, though we don't do that so much anymore. Pertussis, what you'll note on lab findings is an elevated white count with a lymphocytosis. Kids with pertussis should be treated with erythromycin or azithromycin, and then household and close contacts should be treated with prophylactic antibiotics. This is a big bulging ear. This is otitis media. You guys know why kids are at risk, because they have shorter, more horizontally stationed tubes, which increases the risk of fluid behind the TMs and then that fluid becoming infected. The most common organisms for otitis media are strep pneumo, non-typable Haemophilus, so not Hib, but non-typable Haemophilus, and Moraxella. Let's see, in terms of treatment, high dose amoxicillin is usually first line of treatment. If someone has persistent or recurrent otitis media, then you think about Augmentin. I think you guys know this already. Basically, the AAP guidelines, the American Academy of Pediatric guidelines, are that basically the kids that you should automatically treat with antibiotics for otitis media are kids who are 6 months or older with severe symptoms. So like severe ear pain for more than 40 hours, high fevers, greater than 39, or kids who are under 23 months of age and so if they have a otitis media, or if they're younger, so less than 23 months of age, and they have a bilateral otitis media. But if you have like a young child who's like, say, 15 months old, they have a little bit of ear tugging, they're not that febrile, they have a low-grade temp, and you see like just a one-sided otitis media, you don't necessarily have to treat, or say it's like a 5-year-old, similar symptoms, you don't necessarily have to treat. You can talk with the parents about doing supportive care because most likely it's probably viral, and then starting antibiotics if symptoms don't get any better after 48 hours. So the ones you really want to treat for sure are young kids with bilateral otitis media, or a kid with like a single-sided otitis media who is having high fevers greater than 39 or severe ear pain. Otherwise, some of those kids can just be treated supportively and given antibiotics if no improvement after 48 hours. The other thing I sort of want to mention at this point when we're talking about like sort of infectious disease type things in kids is UTIs. So remember, in our kids who are under 23 months of age, there are certain risk factors that can increase the risk of UTI, and that includes age, less than 12 months, a high temperature greater than 39, history of UTI, if they're an uncircumcised male or female, if they have no other fever source, and another fever source can be an otitis media, a gastroenteritis, or if they have fever for more than 48 hours, you should consider getting urine in them to rule out a UTI. In this UTI calc, they include URI as URI and gastroenteritis as like other possible fever sources. Then in reality, I think a lot of us will still get urines in kids who have a little bit of URI symptoms or vomiting or diarrhea because studies have shown that they're still at increased risk for having a UTI. If you have a kid who has a confirmed first UTI and they're between 2 and 24 months of age, you should advise them to go when they follow up with their pediatrician to discuss the UTI, because that age group, 2 to 24 months of age with their first UTI, should get an outpatient renal and bladder ultrasound to make sure there's not some sort of anatomic problem predisposing them to having a UTI. All right. Let's see. This is a kid who presents with these are 2 different kids, 5 days of fever, 6 days, let's say 6 days of fever. And you notice that he's got these fissured lips, this cracked tongue. He's got swelling of his fingers. He's got a rash. He's got an enlarged cervical lymph node. He's got non-suppurative conjunctivitis, so his eyes are red, but he doesn't really have any purulent discharge. This should make you think of Kawasaki, which, as you know, is a vasculitis involving medium-sized arteries. Most cases occur in kids younger than 5 years of age. We worry most about the cardiac complications that can occur with Kawasaki. It's the most common cause of acquired pediatric cardiac disease in the US. Criteria are fever greater than 5 days, and then 4 of the 5 of these criteria here. There are 3 phases to Kawasaki disease. The first phase is the acute phase, lasting for the first week and a half. During this time, their most common cause of death is myocarditis. After the first week and a half until about 3 weeks, they'll start to look better. This is when they have thrombocytosis. This is where you might start to see periungual desquamation. During this time, they're at high risk for having a coronary artery thrombosis because they're so, their platelets are so high. During this time, they may, mortality may be due to MI, aneurysm rupture, myocarditis. And then there's the convalescent phase after about 3 weeks. At this time, their platelets normalize, their ESR normalizes. They may look really good, but if it's not been diagnosed and treated appropriately with IVIG, they may have death due to MI, thrombosis, also aneurysm rupture. In kids who are suspicious are having Kawasaki disease, they need to be admitted for IVIG. Cardiology needs to be consulted to do an echo. They're treated with IVIG, high dose aspirin, so 80 to 100 milligrams per kilo per day initially. What you worry about is the risk of coronary artery aneurysm, which is about 20 to 30% in untreated patients with Kawasaki. They can also develop gallbladder hydrops and meningoencephalitis. Febrile seizures, most common seizure disorder in kids. Usually they shouldn't have a febrile seizure after 6 years of age. If it's after 6 years of age, then you worry something else is going on. A simple febrile seizure is defined as lasting less than 15 minutes. It's generalized, so it's not focal. It happens only once in 24 hours, and there are no neurodeficits. These kids, if you think that they have a febrile seizure, they need to be watched until they sort of return to baseline mental status. It's usually within an hour or two. If they don't, then you need to worry about something else is going on. So like maybe meningitis, and you should do an LP in them. You should also consider an LP in recurrent or prolonged seizures. So, I mean, practically speaking, sometimes you'll have kids who have more than one febrile seizure in 24 hours, and we don't automatically LP them as long as they go to baseline. Partial seizure also doesn't go along with simple febrile seizure, and they may need more of a workup. They may need neurology consult. Parents should be counseled that there is a high risk of recurrence and that there's really nothing to do about it. And these kids don't need to be on anti-epileptics routinely. Infantile spasms are different. I don't know if you guys have seen infantile spasms. They're basically funny looking spasms, and the kid is otherwise well appearing, but prognosis can be bad. So flexion extension of the trunk lasting less than 1 second. They're not generalized. So the kid is awake during the entire time. If you're concerned for infantile spasms, these kids need to be admitted. They need to get EEG. This is sort of a key phrase. You'll see hips arrhythmia and 50% of EEGs. They're at risk for developmental delay and other complications. I'm going to skip through this slide about VP shunts. One thing I do want to point out that's a little bit different in kids with VP shunts who have shunt failure is in kids who have fontanelle, like if they still have an open fontanelle, they may not present until a little bit later because the fontanelle is almost like their pop-off valve. And so you may see a bulging fontanelle. You may also see that their head circumference is just getting bigger and bigger, and that's what clues you in that they have elevated ICP. They can also get something called sunsetting eyes, where basically it looks like they have an upward gaze palsy, so that basically their, I guess their iris or their eyes are sort of in the lower parts of their orbit, and that should clue you in that there's elevated ICP or shunt malfunction in a patient who has a VP shunt. All right, I'm going to skip through this. All right, rectal bleeding in kids. Most common cause is anal fissure. So rectal bleeding, always look at the perianal area to see if there's a fissure. In young infants, you should also, young infants who are breastfeeding, you should think about swallowed maternal blood. You can do the app test to differentiate between maternal versus fetal blood. Usually this isn't really that necessary, but that's what you can do. And sometimes the moms don't even know that they're having bleeding when they're breastfeeding. And so the way you can sort of pick this up is you can have the baby breastfeed in the emergency room, and after about 5 minutes where they have a good latch, you can then ask the mom to take the baby off, and then you can see if mom is bleeding from her nipples at that point. Other reasons for having rectal bleeding in a pediatric patient is a Meckel's diverticulum, infectious gastroenteritis, colitis, juvenile polyps. Meckel's, let's just talk about this briefly. This is a true diverticulum with heterotopic tissue in the wrong place, so gastric mucosa is in the wrong place. And what can happen is this ectopic gastromucosa can secrete acid, causing an ulcer somewhere like in the colon, for example, and you can get painless rectal bleeding. This is the most common cause, most common presentation for a Meckel's. The way you diagnose a Meckel's is by isotope scan. Complications of a Meckel's are intussusception and internal hernia, volvulus. Also, inflammation of the Meckel's can sometimes be an appendicitis mimic. All right, so say that this is an upper GI study from, I don't know, 8-week-old presenting with just persistent emesis. I had a case like this a few months ago where it was actually a younger infant, probably about, I don't know, 2-3 weeks of age, just like lots of emesis, and it was a very large volume. And eventually it became bilious, like it was actually truly bilious. And we got a plain film, we got an upper GI study, and it turns out that it was a midgut volvulus. So midgut volvulus occurs because of congenital malrotation, which results in an incomplete attachment of the bowel to the mesentery. These kids usually present pretty young. I've seen it sort of like in the early, like month or 2 age group, but it can present under a year of age. You worry about it when there's bilious emesis, when there's a distended abdomen, when there's a tender abdomen. You can get a plain film, and you might see dilatation of the stomach or duodenum. But what's going to be confirmatory is an upper GI study. And once you diagnose it, basically ped surgery needs to be involved right away. All right. This is a kid, let's say that they're 18 months old, just sort of fussy for a day or so, and now really lethargic and vomiting. They look really tired on exam. Their belly is a little bit distended. You get a plain film. You see this kind of here, and you see that there's not much gas. And so this should make you think of intussusception. Intussusception is the most common cause of obstruction, intestinal obstruction in the 3 month to 5 year age group. It's usually in the younger kids. Ileocolic is the most common place for intussusception to occur. The classic triad that we all learn about during med school, which is intermittent colicky, abdominal pain, vomiting, current jelly stools, it only occurs in about 21% of cases. And remember, the current jelly stools is a late finding. That's usually because they have ischemic necrotic bowel at that point. Sometimes you'll get the classic history of sort of this intermittent colicky pain, like where they're fussy crying and then they fall asleep. But honestly, like I've seen it present as just sort of unexplained lethargy and fatigue and maybe some recent GI symptoms. Stool may be guaiac. You may see some findings on x-ray, but the way you diagnose it is by getting an ultrasound. The way it's treated is either with an air enema or a barium enema. If it's perfed, that needs to be operated on. There's a 5 to 10% recurrence after enema reduction of intussusception, 2 to 5% after a surgical reduction. So kids with intussusception, even after a reduction, even after they look good, need to be admitted for observation. This is from, let's say, 5-week-old infant with lots of vomiting, projectile vomiting, otherwise happy, afebrile. This is an ultrasound. This is the stomach. This is the pylorus. So this is a pyloric stenosis. There are certain criteria for diagnosing pyloric stenosis on ultrasound. Think of the number, the pi. So 3.14. So 3 refers to muscle thickness. So upper limit normal is 3 millimeters. 0.14 or 14 refers to length. So upper limit normal for length of the pylorus should be no more than 14 millimeters. So more than 14 millimeters or in length or bigger than 3 millimeters in diameter on ultrasound should make you think of pyloric stenosis. These kids usually present in the first month of life. There are certain risk factors. So firstborn male, it's diagnosed in ultrasound. The infant's usually well appearing other than they're just really, really hungry. You may feel an olive-shaped mass in the right upper quadrant. I think I've felt that once in 20 years. The classic presentation is that they're dehydrated with a hypochloremic, hypokalemic metabolic alkalosis. But honestly, these days it's diagnosed so much earlier than it used to be that the kids really aren't having any sort of electrolyte derangements when we diagnose it now. The way you diagnose it is on ultrasound. these kids need to be admitted for IV fluids, electrolyte correction if they need it, and then ped surgery will do a pylora myotomy. All right, let's move on to orthopedic stuff. We're sort of in the home stretch. Okay, so kid comes in with leg pain, extremity pain. Let's look at this x-ray on the right first. So this is the leg. Here's the femur and then tib fib here. Epiphysis of the femur. Here's the epiphysis here. There's the physis. Here's the metaphysis. And you can see here that there's a lucency through the metaphysis. This is called a bucket handle fracture. So bucket handle fractures are metaphyseal fractures that basically result from shear force being applied to the extremity, either from shaking or pulling. And so a metaphyseal, a bucket handle fracture, or you can sometimes see a metaphyseal chip fracture where you just see sort of a chip right here in the corner of the metaphysis. Those are pathognomonic for non-accidental trauma or child abuse. Here, this is from an older kid who got his leg caught like in a overturned radiator. And so he has a spiral fracture right here of his tibia. This was, I think, a 6-year-old, but if you have a spiral fracture in a kid who is non-ambulatory, then that is also pathognomonic for non-accidental trauma. It suggests that there's some sort of twisting motion. A spiral fracture of the tibia in a kid who's just learning how to walk, however, is very common. That's called a toddler's fracture. It's basically created by a toddler planting his or her foot and then just sort of losing their balance and twisting their leg and sustaining a fracture that way. So that is not pathognomonic for non-accidental trauma. Other things that should make you worry about non-accidental trauma include rib fractures. Remember, young kids, their rib cage, their bones in general are much more pliable. And so when you have, for example, chest trauma in a young child, that force is more likely to be transmitted into the intrathoracic cavity than it is than to the ribs. And so they're less likely to get rib fractures. So rib fractures, especially multiple rib fractures in different places at multiple stages of healing, are concerning for non-accidental trauma. Complex skull fractures, cigarette burns, immersion burns, and a glove stocking distribution are also concerning for non-accidental trauma. Kids who you're concerned may have non-accidental trauma should all get an ophthalmology exam. So this is a retinal exam from a kid who has shaken baby. So this is also like these multiple retinal hemorrhages are concerning for non-accidental trauma. If you're suspicious of non-accidental trauma, again, be concerned about shaken baby and a younger infant. They can also present with unexplained seizures, altered mental status, respiratory distress, and have non-accidental trauma in your differential. I remember I had a kid when I was a peds resident, like presenting from an outside hospital. This was when I was in San Francisco, getting transferred to UCSF for basically meningitis / encephalitis. But then when he got to UCSF, he had like retinal hemorrhages that we could see in opto exam. And so he was like child abuse, shaken baby, and not meningitis. Basically, kids you're suspicious who have non-accidental trauma, their workup should include labs, coags to make sure there's not some sort of issue with their clotting that's causing them to have easy bleeding, skeletal survey to look for other fractures, head CT or opto exam, and then obviously child and protective services needs to be involved. All right, let's move on to other ortho stuff. So Salter-Harris fractures are fractures that involve the growth plate. There are 5, I guess, classes or types of Salter-Harris fractures. As you go up higher in number, you're at greater risk for growth disruption, and that can become a problem because then you can have like a rotational deformity of the extremity or a limb length discrepancy. The way I remember the different Salter-Harris types is by remembering the word me, M-E. So I remember that 1 and 5 are basically through the growth plate only. 1 is a fracture through the growth plate. 5 is actually a crush injury involving the growth plate. 2 is M, so metaphysis and physis. 3 is E, epiphysis and physis. And then 4 is M-E, me, metaphysis, epiphysis, and physis. The most common Salter-Harris fracture is a type 2 Salter-Harris fracture. The most common fracture in the pediatric population is a clavicle fracture, but this is another common fracture here. So foosh onto an outstretched hand in a younger sort of school-age kid. you get a true lateral film of the elbow. And you notice here, there's a posterior fat pad, there's an anterior fat pad, and you can see that the anterior humeral line, if you trace it down, it should in a normal, in a patient who doesn't have a fracture with displacement, it should intersect the middle third of the capitellum. If it doesn't, then you should be concerned that it's a supracondylar fracture with displacement. Supracondylar fractures are at higher risk for having neurovascular compromise and compartment syndrome. So with these kids, ortho pretty much should always be involved in the care of these kids. Sometimes if it's a non-displaced fracture, those kids can go home with a splint and they can, have close ortho follow-up afterwards. If it's a displaced fracture, usually those kids need to be admitted and they really need to be monitored carefully to make sure they don't develop a compartment syndrome, which can lead to a Volkmann's contracture. All right, now let's move on to hip pain. So younger kid comes in with hip pain, a little bit of a fever. We always worry about septic hip versus toxic synovitis. Septic hip, we're always taught is sort of, they look toxic, they're irritable. You see an infusion and ultrasound. These kids need to be admitted to ortho with the washout of their joint space, and they need to be started on IV antibiotics. And that's different from toxic synovitis, which is kind of the same age group, but non-toxic. This is more a diagnosis of exclusion. So this is after you've made sure that they don't have criteria that go along with a septic hip. They can be treated supportively if it's toxic synovitis. We use the Coker criteria for helping us differentiate between a septic hip versus transient synovitis. So you look at these criteria. So non-weight bearing, how high is their temperature, and then you look at their ESR and CRP. If they have one positive criteria, then it's about 3% probability of a septic hip. 2 criteria, 40%. 3 criteria, 93%, 4 criteria, 99%. In general, practically what I do, if a kid really is non-weight bearing with hip pain, I'll send off labs, I'll do a workup. I usually will get ortho involved. All right, let's move on to another hip pain case. So 5-year-old kid comes in with hip pain, maybe knee pain that's actually referred from the hip. You get a pelvis view and you see this. So here you can see there's this femoral head looks really sort of, I guess, ratty. And so this is leg cavity perthes, which is basically osteochondrosis of the femoral head. It usually presents in a younger age group than kids who have SCFE. They'll present with a limp, groin pain, hip pain. They don't have fevers. They're not toxic. So you're not worried about a septic hip. They'll have normal inflammatory markers, a normal white WBC count, and you get the X-ray and you see the typical radiology findings. Contrast leg cavity perthes with this kid who's like an older kid, say 13, adolescent, pre-adolescent, maybe male, maybe a little bit heavier, maybe going through a growth spurt. This is a SCFE or slip capital femoral epiphysis. Sometimes there might be a little bit of a recent trauma that they're sort of focusing on, but usually it's trivial. And what you'll see on X-rays, you'll see posterior inferior displacement of the femoral head. 40% of these kids will have bilateral involvement, and so you need an X-ray of both hips to make sure there's not bilateral involvement. All right, now let's move on to pediatric rashes. To say that this is a kid who is not vaccinated, who basically has a few days of URI symptoms, and then they develop a rash starting in the face, ears area that then sort of spreads to the rest of their body. You can see it's this macular papular rash. You can look in this kid's mouth. Obviously, these are different kids. And you see these little white lesions on the buccal mucosa. So this should make you think of measles. These little white lesions are Koplik spots. And again, a few days of like sort of viral symptoms followed by the rash starting up here on the face and then spreading downward. Let's see. And that is a little bit different from rubella, which is German measles, which will also have sort of this few days of malaise or throat viral type symptoms. They will have Forsheimer spots, which are different from the Koplik spots. The Forsheimer spots are petechiae in the soft palate. They're not specific to rubella. You can also see it with scarlet fever. But what's characteristic of rubella or German measles is they'll have lymphadenopathy. So suboccipital, postauricular, posterior cervical. Another kid with a rash comes in. Basically, he's had high fevers, 104, 105 for a few days without any sort of other viral symptoms. And then they defervesce, and then this rash appears. And so this is a very classic history for roseola, which is caused by HHV6 or HHV7. There's nothing to do about these kids. These kids are well. This dewdrop on a rose petal, you guys know this, itchy rash. This is chickenpox or varicella. Most kids are vaccinated these days. Sometimes you can still have a mild chickenpox even with vaccination. You guys know that they stop being contagious only when all the lesions are fully scabbed over. Let's see. Just a few more. It's summer. Kid comes in because they're not taking POs well. And oh, by the way, they also have this rash on their hands and feet. This is Coxsackie, hand, foot, and mouth disease. You basically treat it supportively, make sure they can take POs. This is another kid with a rash, this slap cheek appearance. They might have a little bit of fever, a little bit of headache, a little bit of myalgia. This is a very sort of characteristic rash of Fifth disease, which is parvovirus B19. The kids are no longer contagious once the rash appears, but the problem with Fifth disease is if a mom who's pregnant, with a toddler child at home, is exposed to this child, they can develop hydrops fetalis. And then also patients who have any sort of chronic hemolytic anemia, if they get parvovirus B19, they can develop an aplastic crisis. All right. Last slide is on conjunctivitis. This is like an older kid, obviously 6 years old, most likely viral. Be aware that neonatal conjunctivitis is oftentimes not viral. First few days of life, if you have a neonate coming in with conjunctivitis up to about 5 days of age, and it's like purulent discharge with injected conjunctiva, you should think of gonorrhea. And she also talked to mom about her prenatal history. True conjunctivitis in an infant 5 days to 5 weeks of life, think chlamydia, and then up to about 5 years of age, you can think of strep or Haemophilus. In terms of how we treat conjunctivitis, if we're concerned about gonorrhea and chlamydia, basically, if it's gonorrhea, you want to give them both topical and systemic antibiotics, penicillin. If it's chlamydia, you give them oral erythromycin. Neonatal conjunctivitis is pretty rare these days because newborns if they're born in a hospital, will get erythromycin eye drops to prevent neonatal conjunctivitis. So unless they were born at home without adequate care after they were born, you don't really have to worry about it that much. You don't have to worry about it at all. All right. And that is the end. Any questions before Tedeschi takes over? All right. All right. Thank you. It's all yours, Chris.
Hey, guys.
Thanks, Sophia.
Hi, Sophia.
You're welcome. Oh, I need to stop my screen share, huh?
Yeah, thank you, Dr. Lynn. That was great.
Thank you all. See you soon.
Bye.
Have a good night.
Good night.
You guys want a short break, or you want to just power through this? I promise I'm going to be done in less than 45 minutes.
Let's power through. It's been a long day.
Yeah, this is the bitter end, right?
It's not bitter. It's,
No, this is the bitter end for sure. It's been a long day all around. I'm going to share. I'm going to rearrange this. Uh-oh. Thanks for joining. I know we're recording, so I'm just gonna kind of get through this without stopping for too much in terms of questions or anything. But if there are any questions or something doesn't make sense, obviously, just stop me. I'm not gonna really be able to look at the chat. So this is like the least high yield review session, but it's cool. And there's always an opportunity to pick up a couple of points on the in-service here. I'm in no way going to try to give you guys a comprehensive review of environmental illness or injury, but there are some topics here that are very EM specific that don't really appear, like in other specialties like ortho or peds. And the ABEM loves that stuff because it's kind of EM specific. So, I've done this comparison, I think, before in the past. you guys are just squirrels trying to get nuts on this test, right? You just got to collect these little points as they go along. So I'm going to try to just go through this with the idea that we're going to get you as many acorns as we can. And then again, I can make the slides or like a PDF available if you want later on. So the environmental section, according to ABEM, is 2% of the content of the in-training exam. So feel free to, I guess, pay me 2% of your attention as we go on. But hopefully this is good for 1 or 2 points that can kind of help you push up to whatever bar you want to push yourself up. I used to have a picture of a pig and a truffle here, but I changed it to the squirrel. And then I realized that it's kind of relevant to environmental illness. So squirrel trying to get nut review points. Just quickly, squirrels are rodents. They're small rodents and therefore almost never or virtually never transmit rabies. So remember that squirrel bites, really not rabies appropriate. Nonetheless, raccoons are a very big transmitter of rabies. And it follows, therefore, that raccoons are not rodents, which is true. And bonus points, beavers actually are rodents, but they're big rodents, and they actually have been reported to transmit rabies. That's all I got for rabies. So in terms of environmental illness, ABEM says that these are the sort of the topics that are focused on in the environmental category. This is what I'm going to use as sort of an outline for the next few minutes. There's an enormous amount of stuff here, and I think the idea is to know the key sort of terms or responses for each of these, or the key points is really kind of most important without needing to know kind of the in-depth level of complexity that you might for some some of the more in-depth topics like cardiology or peds or something. So it's bites, dysparism, electricity, altitude, submersion, heat and cold, and radiation. That's the core content for environmental for ABEM. So it's a small percentage, but again, it's a lot of EM unique stuff, which is tempting for them to put on the test. So let's get going quickly. I'll run some questions by you guys as well. Bites and envenomation includes not just snakes and scorpions, or snakes and insects and arthropods, but also marine organisms, mammals, reptiles. Here's a quick question, right? And snake bites are common. Rattlesnakes are the most common snake in the US, most common snake bite. Which of the following most accurately describes the clinical effects of crotolid? So when you hear crotolid, think pit viper. When you hear pit viper, think rattlesnake. In the US, for the most part, we have 2 main categories of venomous snakes, crotolids and elapids. The crotolids are far more common. I imagine they're far more common on the test as well. So if I take a look at these, I think, well, what does crotolid toxin do? What do rattlesnake bites do? And it's generally, I think of it as kind of like the hematologic-y stuff, right? The bloody stuff. It's coagulopathy, it's bleeding, it's platelet dysfunction, it's clotting problems. If there's a question about with the response includes something about a clotting time, that's kind of the answer. The rattlesnakes cause all of this local tissue stuff, as well as coagulopathy, long bleeding times, long clotting times, and platelet dysfunction. Each of the other choices attached to this question are the answer for a different envenomation. Probably the most important is that this top one, blurred vision, paresthesias, ptosis. All of these are kind of like neuro-ish symptoms. And that's when I start thinking about elapids, right? So the paralysis, the respiratory depression, the paresthesias and motor dysfunction, ptosis, those are more frequent with the elapid snakes, and those include, in the US, just coral snakes, but that's kind of like the real big bad snakes, cobras and kraits and mambas and stuff like that. There is some overlap in these snakes, but this is kind of like the classic pattern for envenomation. Dermatonecrosis is kind of a trigger word, and that the answer to the question in which you see the word dermatonecrosis is brown recluse spider, right? And that's where you get that black eschar that kind of is necrotic skin. Whip-like is a code word for jellyfish tentacles, right? So if people have these long, stringy, long red lines you'll see on a limb or something in a picture, technically that is a It's kind of more common with the jellyfish. Envenomation, local pain. We talked about hematologic stuff, and then migratory severe pain, again, in this kind of category. Think about black widow spiders, right? So I kind of think about this like the brown spider causes the black skin thing, right? The black eschar, and then other way around. The black widow spider causes a lot of pain. Crotalids are probably the most common snake question. Pit vipers, pain, edema, bullet, we talked about that. All those hematologic effects. The snake with the elliptical eyes is the venomous one. That's the rattlesnake or the crotalid, and they're called pit vipers because they have those little pits that are heat sensing, these heat sensing organs that are inferior to their eyes. The slit-like eyes are the key here. So how do you treat this stuff? There are plenty of antivenoms. The most common answer on a test for a crotalid bite is the product we call Crofab, which is a polyvalent immune fab, the first thing there. There's another product on the market which has been out for a while now and may find its way to the test at some point it's the FAB2. It's the picture kind of on the right there, which is just the FAB portion of the antibody. That's derived from horses. Crofab is derived from sheep. And then the other sort of thing to remember about some rattlesnake and other envenomous snake bites are that there is such a thing as a dry bite, which is a bite in which the snake didn't discharge any venom. And generally the ED standard for that is to observe the patient for, say, 6 to 8 hours. In the field, the answer is always to evacuate because you don't know if it's a dry bite in the field. Okay, so here's our two favorite spiders, the most common spiders on the test. Sorry? No. I mean, one's brown and one's black, so that's pretty easy. You can see the little violin shape on the brown recluse. That's what kind of keys you off to that. And then on the black widow on the right, you can see that red hourglass shape, and that's what keys you off to that it's a black widow. If they show you a picture of these spiders, you should see one of those two kind of like identifying features. So that is my 2 cents on envenomations. The other one you might commonly run across is scorpion stings. Scorpion stings generally affect young kids in the Southwest. If there's like a 5-year-old in his backyard in Arizona on a hot day, kind of that's a setup for a question or the answer being a scorpion sting. There is an antivenom for this. The mortality is very low, but there's a lot of sort of neurologic effects that you'll see. It will be nystagmus, roving eye movements, seizures, perhaps, altered mental status. And the answer to that question is generally scorpion.
Dan Golden says the most common bite he sees is scorpions out in Vegas.
I can make an off-color comment about that, but I'm really not gonna. Yeah, it's super common. I mean, and it's kids. In an adult, it's not, there's not that much morbidity, but if you ever work with Rishi Goyal when he used to work out in Arizona, he has stories of seeing these things. Like it's just not uncommon. Okay, for those of you who dive, the disparism questions are not that deep. Just kind of remember your pressure volume relationship, and you should get away with most of the common sense stuff. Disparism as a clinical entity is sort of barotrauma of descending. So remember, as you descend, there's more pressure, and that makes less volume in any closed space. So those red eyes you see on the right there are, I don't know if any of you guys dive, or mask squeeze. Remember that fixed volume of air in your mask will decrease in volume as you undergo greater pressure, which is why you clear your mask or put air in your mask as you go clear your mask as you go down. Same deal with inner ear, sinuses. Anything with an air pocket is subject to this. So, teeth often have a little bit of air in them, sinuses, and certainly you can see that subconjunctival hemorrhage. The bad stuff is decompression sickness. This is when you're going in the other direction. Remember, as you go up, little bubbles become big bubbles, which is why divers have staged, ascents and have to stop to denitrogenize, to degas, basically their blood. So this is the bends, right? So decompression sickness, the symptoms are vague and widespread, and they can be cutaneous and localized. I I think that's probably less common, but you see someone with just extremity pain. But in general, neurologic symptoms, pulmonary symptoms, remember that gas is getting released into the tissues. It causes everything from just inflammation to life-threatening emboli or vessel obstructions. The big bad one, obviously, is an arterial gas embolism. That's from a big bubble that ends up in an artery. Maybe it goes to the brain, maybe it goes to the heart. And if the story of the diver who surfaces in arrest is someone who they're prompting you to think about arterial gas embolism. No flying for 24 hours after a dive. Sometimes that shows up on the sort of injury prevention side of stuff. That is the general advice you want to give to people. If you don't know about the right answer for treatment for any of these questions, it's hard to argue that hyperbaric oxygen is wrong for any of them. So that if that's an option and you don't know what you're doing, it's a pretty safe bet. Diving. All right, we're flying right along here. Electrical injury. This is another one of these things that doesn't really appear anywhere else. And so something like this, I feel, shows up either on the oral boards or in the in-trainer or the boards, the written boards, with some regularity. You can go back to physics and study, V equals IR and all that, if you like. But in terms of high yield facts, this is a review question. Which of the following is true? Anterior shoulder dislocation are most commonly seen. Actually, it's posterior, right? Cardiac dysrhythmias are frequently delayed. Actually, not so much. Cardiac dysrhythmias, when they occur in electrical injury, occur off the bat, right? So if someone shows up to your ER in a sinus rhythm, the chance that they will deteriorate into some dangerous rhythm after an electrical injury is very, very small. And therefore probably don't need observation for that. Lermet sign can be seen after a lightning injury. This is a stupid trick where they're trying to make you think of a word that starts with L. Anybody knows what Lermet sign is? It's the sign that you have it's a sign of spinal cord pathology when people feel sudden shooting pains when they flex their neck or something and they have a C-spine problem. D doesn't sound so great either. The most important complication from oral commissure burns is immediate bleeding. This is the kid who bites the electrical wire question, and it's the picture of the kid with like a thing on their lip, like a scab or a scar, right? And the answer to that question is delayed labial artery bleeding, right? This is kind of a very high yieldy kind of cherry point for the boards. They love this one, and I've seen it with a picture. And then when similar voltage are used, alternating is more dangerous than direct. That sounds right, because none of the rest of these sound right. If you just think about the differences between AC and DC, AC is the one that causes tetanic muscle contraction, right? It's the one where you grab onto something and you can't let go because your flexors are overpowering your extensors and you have continued injury. Right? DC is the one where you get thrown back. That's the third rail of the subway. Brief injury, less bad. AC current, higher rate of injury, higher rate of dysrhythmias, and more bad. So for this question, you'll remember that posterior shoulder dislocations are associated with electrical injuries and lightning for that matter. Cardiac dysrhythmias are often immediate. It's not Lermet sign, but it's Lichtenberg, the L word that they're fishing for here. And I'll show you a picture of that in a second. And then again, delayed bleeding from, again, the kid with an oral electrical burn is a pretty good board question. Okay, which brings me to lightning. So you guys probably can't see this picture real well, but that back there is a picture of Lichtenberg figures. It's a transient cutaneous finding that is pathognomonic for a lightning strike. So if you see that picture that looks like a dendrite or a big fern on somebody's back or leg or something, the answer is lightning. Lightning is bizarre. It's kind of hard to understand. I don't know if anybody really does understand it. It's best defined as a unidirectional massive impulse of current. It's not AC nor DC, although I've seen a ton of reference materials that do define it as one of those. I would hope that the boards doesn't go down that road. The most common effect of, obviously, of a lightning strike can be cardiac arrest. We commonly see ruptured tympanic membranes, secondary trauma, delayed complications include cataracts, neuropsychiatric problems, and this idea of secondary arrest. So imagine you get struck by lightning, all of your myocytes, all of your respiratory centers get kind of reset, and then it takes some time for them to sort of come back online. And your cardiac myocytes may come back, regain their automaticity before your medullary respiratory center starts you breathing again. And then you arrest again from hypoxia. So that's kind of what this term secondary arrest is, which is why you need to breathe for these people. This idea of reverse triage is definitely a possible question. Cardiac arrest from lightning strike is reversible. So, and oftentimes this is presented as like a mass casualty incident. You know, 5 golfers are on the 18th hole and they all get struck, and one of them has no pulses, and who do you take care of first? And they're trying to trick you into thinking, you know, this is a mass casualty. This guy has no pulse. He should be like a black tag. In the case of lightning, that is exactly the opposite. And so that's called reverse triage. That's a Lichtenberg figure. Again, keep your eye out for a photo like that. It's a freebie if you see it and you recognize it as a sign of lightning. Oz, you got to go to work. Okay, altitude illness.
Yes, I do.
See ya. Better you than me. The answer to the altitude question is to go down, is descend. There's all kinds of subtleties here. There's all kinds of medications that are indicated for different reasons. If the option for descent is given to you in a question for high altitude illness, acute mountain sickness, or cerebral edema or pulmonary edema, it's hard to argue that that's wrong. And on the boards, that's a really safe bet. So here's a board question, a review question. 52-year-old guy is climbing Mount Everest. He just got to base camp. He wants to spend a couple of days acclimating there, starts feeling sick. Which of these is an indication for immediate descent? And what they're trying to get you to do here is tease out the very common symptoms of acute mountain sickness with the very serious, possibly deadly symptoms of cerebral edema. And really simply acute mountain sickness, you know, many people have experienced it. If you've ever flown to a high altitude place to go skiing or climbed a mountain or whatnot, you have experienced maybe acute mountain sickness. But it doesn't make you ataxic. So ataxia is by definition not part of acute mountain sickness. And all of this other stuff is. And as you can, you know, this is kind of a common sensey question. You know, all of these other, you know, headache, fatigue, malaise and fatigue, I don't even know if the difference between those two is, right? Like, those are not good answers to this question, even if you have no idea what they're talking about. Same goes with nausea, like everybody's nauseated, right? Ataxia here stands out a little bit, even if you don't know any of this stuff. And it's the right answer. It's just not part of mountain sickness, but it is a hallmark of cerebral edema. And the treatment for high altitude cerebral edema is descent. It's a better answer than steroids, which may be offered to you. Dexamethasone is a treatment for high altitude cerebral edema, but the definitive treatment is descent. Okay. Let's see. Here's another question about high altitude illness. A pair of mountain climbers, they're also climbing Mount Everest. This is such a silly question. Both team members felt fine on day 3. The next day, one guy noticed that the other person looked off balance and drowsy, used a rock to stand, staggers and falls backward, lands on his backpack. Assuming climber A has the capability of all the following interventions, what should climber A do? Descend, right? It's always the right answer. So you can cross out, you know, B and D and E on this question. And then you're faced with the problem of figuring out whether acetazolamide or dexamethasone is the best treatment for what they're describing in this question, which includes ataxia, which means high altitude cerebral edema. And as we just mentioned, the treatment for cerebral edema besides descent is dexamethasone. Acetazolamide is a medication that's used to prevent and treat acute mountain sickness, but there's no great evidence that it's helpful in some of this other stuff. So descend, steroids. HACE, Decadron. The other flavor of severe altitude illness is obviously high altitude pulmonary edema. The treatment is descent. They may offer you some medications that are possible to use in that setting of pulmonary edema. The most common is probably nifedipine. The other most common is probably sildenafil or Viagra. Both of those reduce pulmonary hypertension, and their treatments for high altitude pulmonary edema. Nonetheless, descent is the option. They also may show you a chest X-ray that looks like pulmonary edema, and then the most likely answer is HAPE or high altitude pulmonary edema, although anything else that causes pulmonary edema is obviously on your differential. High altitude pulmonary edema is a non-cardiogenic pulmonary edema. So people do not have the signs of CHF. It's not heart failure, and it's very asymmetric. So patchy edema is also kind of a hallmark of HAPE, high altitude pulmonary edema. Okay, from the mountains to the desert, talk about heat illness a little bit. So this is a 65-year-old with no medical history or unknown history, comes in by ambulance with altered mental status. He appears very dry and his skin is warm to the touch. All right, fine. I don't know if I care about that. Found unconscious in his parked car on a hot summer day. So you kind of already know where this question is going if you're trying to just game it by the question and you don't really know what else is going on. Vital signs, a little tachycardic maybe. Rectal temperature is 40.5 degrees Celsius. So, this is kind of like the classic question where they need you to, one, figure out the diagnosis, and then step two, figure out the treatment for that diagnosis, right? So they're giving you heat stroke here because the patient is hyperthermic and altered, right? There's no, particular temperature cutoff. There's no vital sign. This is an unconscious patient who is hyperthermic, and unless you think he's septic, which is, clearly or hopefully clearly what they're not going for in this question. Basically the question is, how do you treat heat stroke, right? And the best answer to treating heat stroke is immersive cooling, or what you'll see as cold water immersion or ice water immersion. The other reasonable answer is evaporative cooling. It is standard of care for heat stroke. It's a choice on this question, which I think is a little bit subtle. It's probably not as rapid as immersive cooling. And so they're asking you what's the most rapid method. And so putting somebody in a tub full of ice water is the most rapid question, or the most rapid treatment for heat stroke. Evaporative cooling is a treatment for heat stroke, and, in a different set of choices, that might be the best answer. But I think if they're asking what's fastest, it's cold water immersion or ice water immersion. The rest of those choices are just kind of meant to lead you off in the wrong direction. Acetaminophen is for fever, but this is hyperthermia, not fever. Dantrolene is for malignant hyperthermia. And it is not shown to be effective in heat stroke, although some studies tried to prove that, but eventually were kind of debunked. And ice packs to the axilla and groin should never be the answer to any question ever. It's not shown to be effective for anything. So that's hot. We'll talk about cold for a second. Hypothermia, just as a kind of like, remember where we're at here. Severe hypothermia is a core temperature of less than 28 Celsius centigrade. That's where the bad stuff happens. That's where altered mental status, cardiac dysrhythmias, cardiac arrest happens. Moderate hypothermia is in that 28 to 32 zone, and then mild hypothermia is in that 32 to 35 zone. And the treatment strategy is here, essentially the colder they are, the more aggressive you have to be with your cooling. And in that severe less than 28 centigrade zone is where there are higher risks of ventricular dysrhythmias. You may come across this guideline of handle patients gently that are in this zone, that, if that's on a question, it's probably a reasonable answer. There's some evidence that that's a thing, because the myocardium is irritable. So mild hypothermia, Just to, remember to treat underlying conditions. Like a finger stick is still the right answer in terms of resuscitation. People who are drinkers need thiamine because this is a hypothalamic dysregulation problem. People who are infected need to be treated for infections, and so on and so forth. For moderate hypothermia, we talk about external rewarming from an active heat source. And then for severe hypothermia, which is, kind of the ED resuscitation question, remember, that people say they're not dead till they're warm and dead, but, in fact, sometimes they're dead. In the case of someone with obvious traumatic injuries, a potassium greater than 10, some people say 12, but an elevated potassium on initial kind of evaluation is an indication not to resuscitate. Obviously, if someone is frozen solid and you can't do CPR, that's an indication. All of these active warming modalities are appropriate. ECMO is probably the right answer on a board question these days, or ECLS, or transfer to an ECLS center or something along those lines. ECMO is pretty much the standard of care for cardiac arrest and severe hypothermia now, and kind of borne out by evidence. Remember, prolonged CPR is kind of the standard for a lot of these cases, and slow atrial rhythms, slow AFib are kind of common rhythms that you might see. So, yeah.
I just have a few questions about like real life management.
Mhm.
Just because this is like something I've thought a lot about, and like I feel like every winter I get paranoid I'm gonna get someone.
Yeah, because
and
it's a
then not.
logistic nightmare.
Yeah. So like in terms of the chest tubes, where are you putting them if you're doing
So
that?
the classical teaching is one of them goes in the midclavicular line
Okay.
anteriorly, and the
Okay.
other one goes in the anterior or mid-axillary line more inferiorly. So it's going in through this one and out through the
Yeah.
lower.
And are these like pigtails, or are you trying to
Well, you
put
got
it
to put a
big?
lot of warm fluid through it.
Yeah.
So, it's like 34 French chest tubes.
Yeah, yeah,
But the answer is ECMO.
yeah.
Like to logistically put together two chest tubes that you can, I don't know, like just in terms of little connector pieces, like how you would manage to get a fluid warmer attached to a chest tube, right? Like you're
What a
going to be
nightmare.
jury rigging something that doesn't work.
Yeah. I feel like you'd be
Um,
like, because the level 1 warms fluid, right?
the level 1 warms fluid, but it comes out of an IV line.
Yeah.
And so you'd have to really make that work somehow.
Yeah. And then in terms of warm, is like 32 reasonable?
30 to 32. Yeah.
Okay.
I think the NYP guide, like policy, says 30.
Oh, okay. Okay, last question. And then the K is something I've heard like a lot of different things about. Is most of what you are aware of and know is like if it's greater than 10, you're basically like protected, if you will.
Yeah, absolutely. And that's also in the NYP policy. Some say 10 and some say 12, so we'd have to go back and take a look.
Yeah.
If the patient is not, not hemolyzed,
Yeah. Yeah.
you have to then that's a reasonable justification for ceasing resuscitation.
Yeah.
The only caveat to that, which would be very weird, would be freshwater drowning, with a large aspiration of fresh water, because remember that's going to make you
Oh,
hemolyze,
sure. Yeah.
right? But in general, most of the guidelines allow that, and so
Okay.
that's probably fair game for a board question too.
Okay. Cool.
Yeah, thanks. Okay, frostbite is the other probably common cold injury that you would see. I saw somebody with frostbite today. She put an ice pack on her shoulder for like 4 hours. It's cool. So, frostbite is both very simple and very complicated. At the end of the day, it's just when stuff freezes, right? So frostbite is local freezing injury. You may see a picture of pale, waxy digits. You may see these big bulla. You may see necrotic digits like that picture on the right. There's all kinds of fanciness for frostbite. The answer is rapid warm water rewarming. So the answer choice that says gradual is not the right one. rapid rewarming in warm water. The temperature is usually 40 or 42 degrees. The only caveat to that is if there's a risk of refreezing. So if you're, in a mountain hut or something, I don't think the boards would do that to you. And then the standard of care for severe frostbite is thrombolysis, right? So TPA, which has been around for a long time now and may show up on the boards. Both of those for severe frostbite are reasonable. There's some subtleties to the timing and everything, which I don't think that they would get into. Iloprost, which is an IV prostaglandin, is not yet approved in the US, but it's pretty cool. And it's like virtually approved, like we expect it in the next couple of months if it hasn't happened already. IV for a frostbite, which is pretty cool. But warm water immersion, don't let it refreeze. It's a tetanus-prone wound, and thrombolytics like TPA. There's all kinds of protocols for TPA, intra-arterial, IV, and I can't imagine that they would expect you to know exactly how to tease that out. The wrong answer is gradual warming or something else that seems like a really long, slow, drawn-out process. Antibiotics are often are not indicated either. Okay, so submersion, drowning. What's drowning? Drowning is respiratory compromise because you are immersed or submersed in a liquid, right? It's not death. It's not cardiac arrest. It's just respiratory compromise because of immersion or submersion. And for what it's worth, all the other terms that are still out there, like dry drowning and near drowning, and I don't know what else, are all without medical meaning. You can refer to a non-fatal drowning for someone that does not die after drowning. Again, from the sort of the injury prevention side, who's at risk of drowning? It's young people. This is for the US. Tubs, pools, teenagers drinking, young men drinking and diving into pools are the risk factors for drowning. Related trauma is not super common. It's generally related to C-spine injury, but really, unless diving into a shallow pool or a shallow body of water or a fall is involved, we don't really worry about trauma too much. Again, drowning can be complicated, but at the end of the day, it's hypoxia, right? So don't overthink this one. There are some guidelines for the in-service people who have drowned, who arrive with a normal exam and a normal oxygen saturation, can be discharged after a brief observation period. Focal findings on a lung exam in someone who has drowned warrant admission. We know that in people who progress to ARDS following drowning, the initial chest X-ray is not predictive, right? So don't let a normal chest X-ray in someone they just fished out of the water fool you if they tell you that they have an abnormal lung exam. That person needs to be admitted to the hospital. Obviously this is a hypoxia problem, right? So this is a place where we don't teach compressions, only CPR. So breathe for the person is also the right answer. C-spine injuries are pretty rare. Again, antibiotics are not the right answer to a drowning question. If there is infection after drowning, it's something weird. And so just, your standard issue vancomycin may not be the right answer anyhow. Although I don't think Zosyn is standard for anybody except us. Finally, radiation is an enormous ball of wax that we don't talk about a lot. This is not the time to go study alpha waves and beta particles and gamma rays because, if you don't know all that stuff already, that ship has sailed and it's not particularly high yield. But there are some important things to remember. What are we worried about, right? Anything from malfeasance to nuclear accidents to unshielded radiation, right? A hospital worker that works, is working in the radiation oncology center is exposed to something and so on and so forth. So a couple of tips for radiation. There's exposure and there's contamination, right? They're different. Like when you get an X-ray, you're exposed to radiation, but you're not contaminated with it, right? There aren't radioactive particles on you. Contamination means that there's something radioactive on you or in you. Radiation syndrome is a dose-dependent phenomenon, right? The more you're exposed to, the sicker you get, and the more you're exposed to, the faster you get sick. There is this prodrome. There might be a latent phase depending on the exposure. This is all really kind of like generic. Acute radiation syndrome goes along this continuum, right? From hematopoietic effects, GI effects, neurovascular effects. Neurovascular radiation sickness is very rarely survivable. And that is the patient that, has which of these patients has the worst prognosis? It's the patient with neuro symptoms after radiation exposure. Which of these patients likely received the greatest dose or the greatest exposure or is most acute is the patient who vomits first, right? So the time to vomiting is correlated with exposure. And that tends to show up as a question sometimes. So just kind of time to vomiting is a relevant measure in radiation exposure. The other thing they might show you is an absolute lymphocyte count, right? So, I don't think anybody's going to expect you to know sort of numbers, but if someone tells you that, the absolute lymphocyte count is depressed or decreasing or something like that, that's the indicator for a bad prognosis. And maybe they'll say their absolute neutrophil count was something, or their platelet count or whatever else. It's the lymphocytes that matter. So looking at the absolute lymphocyte count is probably the best lab marker for a bad prognosis in radiation exposure. Okay. Let's see. Power plant blows up. Gamma radiation, gamma waves travel far. They're not contaminating, but they're exposing. Most people show up. Which of the following is most critical, right? So that's that question. And without reading all of these, the answer is the 31-year-old who experiences vomiting 20 minutes after the exposure. That is the prognostic marker you're kind of looking for. Okay, treating radiation exposure. I mean, this is very deep into the weeds that I would hope that ABEM isn't want you to know everything. The answer here is basically call for help. Sick patients are sick patients, so they need to be resuscitated like sick patients need to be. Decontamination needs to happen for the sake of not contaminating your facility or your staff. But in general, it's taught that, you can address life and limb threatening conditions prior to decontamination. External decontamination, like a shower, can remove 90% of the radiation from a patient. And then in terms of treatment, the only thing that may be out there that's worth remembering for the boards is that, again, there is this hematopoietic syndrome and decreased lymphocytes, and something like GCSF, like granulocyte stimulation. I don't know, that might be an answer floating around out there, and that's kind of a first-line treatment that an emergency physician might need to know. Countermeasures for radiation are very complicated and specific to the type of exposure. We often hear about potassium iodide, and if there's some kind of mass casualty or disaster question related to radiation, you may see potassium iodide tablets. The object here is to saturate your thyroid with iodine before the radioactive iodine that is a byproduct of some radioactive decay can get into your thyroid and cause injury. This is for young people and pregnant people more than anything. And it really is meant to happen, either before the exposure or shortly after. And so, there are all these plans to widely distribute potassium iodide tablets. You can go to prepandsave.com to buy these if you are a prepper, just to have laying around. See, I'm done. That's the Whirlwind environmental tour. It's a lot, but I can send you guys a PDF or something like that. I know it's been a super long day, so I appreciate you even being there. Any questions at all?
Okay, here's a really dumb question.
Ugh.
Do you have to use some weird shampoo or some shit for decon?
Yeah,
for
that's the answer on
radiation?
the question. Weird shampoo. Just put C, weird shampoo or some shit.
Yeah.
Okay, so no, the answer is no. We decon with gentle soap and water. Dilution is the solution to
Yeah.
pollution. They tell you that hot water is not good because like very hot water is not good because it can crack or dry skin. You don't want to cause any kind of like route of entry. And like same for gentle scrubbing, but there's no magic shampoo. It's just like liquid soap, and that's what we have stored for this reason. But it's like the water temperature has to be tepid, and it gets kind of complicated, but nothing special.
Sure. Okay.
Now there are tons of chelators, right? For particular ingestions and contaminations that's like way beyond all this. It's
Mhm.
like the Prussian blue, all of those things, and they're all isotope specific, and I wouldn't sweat it.
Cool.
Cool. Right on. Thanks, guys, for being here.
you. Thank you.
Good.
Anytime. Always feel free to reach out if you guys have any questions.
Yeah. Thank you.
All right, guys. See you. Good night.
Have a good night, everyone.
Right.